Well, good afternoon, everyone. My name is Lance Becker, and I'm a member of the Planning Committee. Again, I would like to thank everyone, all of you, and introduce our first summarizer, who will be Dr. Tom Aufderheide, to summarize the results of the first breakout group on the collaborative.
All right, can I thank you, Lance? So we had a great session. I thought it was really productive. Again, we all reviewed Recommendation 8, which should be indelibly stamped in your brain after this last 1.5 hours. Stakeholders, essentially, to summarize, are just about any stakeholder within the within cardiac arrest. The list is long, but we had some additional suggestions which I thought were interesting and helpful. Medical specialty organizations should include other specialties such as anesthesia, critical care medicine, physical medicine and rehabilitation, neurology, even dental agencies, because they are involved with public access defibrillation and so forth. For NCAA, professional sports and athletes organizations, we defined cardiac arrest survivors to assure that it's survivors, families, and friends of survivors, and non-survivors and rescuers. We probably need some consumer representation, AARP, and that there was support for basic science research collaboration, and the model for that was a basic science collaborative that occurred a number of years ago that formed multiple basic science labs that would do single projects. Another suggestion, which was interesting, is post-resuscitation counseling. That, in fact, does occur now. It is a wide open field, probably needs to continue to grow, but was suggested to be included. In our group, we had unanimous support for the development of some type of national cardiac arrest collaborative. There was no one who felt that there was not value in doing that, and everyone felt that it should be created. We spent some time on discussing after that, well, then what is a collaboration as far as you're concerned? Well, it's formed because it is capable of achieving a collective goal that cannot be achieved alone. It sets national aspirational goals related to patient outcomes, provides a role for and encourages participation of all current and potential stakeholders, by maintaining a neutral position, successfully manages conflict of interest among participating in competition among participating stakeholders, shares leadership among stakeholders to promote continuous innovation, inclusivity, and participation. The benefits and challenges of a collaborative, the benefits were numerous. Summarizing, it was the ability to change professional and national culture, and that is specifically plural. Changing the culture of the public, of EMS, of dispatch-assisted CPR, of hospitals, et cetera. And that collaborative provides a platform for funding from other donors. Challenges are also numerous. Making decisions about membership and government, governance, enacting change, maintaining a focused, effective organizational mission. And that came up multiple times to assure that the group does not do everything under the sun, only addresses things that the collaborative should be good at, allows all of these organizations to move forward with their otherwise own initiatives, and that the collaborative remains focused. Coordinating the numerous stakeholders and actions, and securing sustainable and sufficient funding. The first steps for the collaborative that were recommended collectively by the group was to first identify and convene representative stakeholders. The first strategy was to select a relatively small number of representatives from key organizations. And for lack of a number, we pulled 12 out of the hat, but perhaps somewhere between 10 and 20 individuals from key cardiac arrest organizations to meet. The second strategy, there was concern that that would not be inclusive. There was discussion about having a completely open meeting. Ultimately, our group felt that an open meeting would include so many people as to be unmanageable. The compromise between a select group versus an open meeting was to select a core group from the key organizations, and then either in real time during the meeting or afterwards in terms of website, provide open commentary to the entire stakeholder group within the country. The second recommendation is to meet within 3 months of today to determine the organizational structure and set an initial short-term agenda. To discuss potential funding models and identify key objectives. That's it. Thank you.
Dr. Bradley will be our second summarizer. Richard.
Thank you, Rich Bradley. So our group was very engaged and provided some excellent suggestions and comments which we summarized. First of all, with respect to the collaborative itself. Let's see, oh, I've got the clicker. We agreed with the definition of collaboration. I don't think that there was much difference between our group and the previous. There was a consensus in the room that the collaborative should not be a standard-setting organization, but should work together to obtain a synergy of agendas. There was considerable agreement that there was significant value in establishing a collaboration. We had 22 individuals in our room participating, and there was unanimous agreement that a collaborative would be a valuable step forward. We talked about the stakeholders. We discussed having a restricted group versus an open group. While the correct answer is probably somewhere between both ends of the spectrum, we did feel that there was a need to have broad criteria for being in the group. A number of organizations could be represented in the collaborative, including within the specialized organization category, accreditation organizations, that is people who will require education in sudden cardiac arrest resuscitation, including EMS certifiers. There was an interesting discussion on the role of industry in the collaborative and whether industry should be a part of the collaborative or not, as that was a question we talked about last hour. There was an interesting comment from one of our participants in the room who's from industry, which is that it's not only industry who is potentially conflicted in any action of the collaborative, and really that there are several, if not most, players have some potential conflict in the decisions that the collaborative might reach. We took a show of hands poll, and there was not a unanimous decision, but a probably 2-to-1 majority favoring inclusion of industry in the collaborative. We talked about short-term priorities. Obviously, the first priority would be to get the thing going and established and make sure that it's organized but not get unduly bogged down while getting it running. We talked about the importance of developing educational goals to improve survival from sudden cardiac arrest, and actually 2 areas, both neurologically intact survival and the rate of bystander CPR. So a short-term goal to be establish public education programs and public education outreach. Primarily we talked about ways to overcome the culture of inaction and create a culture of action. And we also set a short-term priority, or recommend a short-term priority, of taking steps and setting objectives to improve bystander and EMS performance. And I think primarily we'd look at EMS performance and also in-hospital performance by implementing proven science. Our longer-term priorities, we developed a few of them. One would be using an effective national cardiac arrest registry with defined levels of both EMS and hospital participation in that registry to set a goal for a long-term sustained improvement in both bystander CPR and overall neurologically intact survival rates. So using the registry to set goals and then implement programs to improve survival and bystander CPR. A second long-term objective would be to develop an effective toolkit, or effective suite of toolkits and educational materials that will allow EMS systems, healthcare systems, and hospitals to adopt continuous quality improvement programs. And then finally, to produce a periodic report on the state of sudden cardiac arrest in the nation, along with national priorities for improving that state. We talked about our goal and mission, and there was a lot of interesting comments, but I think one of the most important things is that we should not get bogged down in a lot of administrative details, and we need to make sure that we're doers and not thinkers. Thank you.
Thank you. Again, my name is Lance Becker, and I chaired the third group. Can I have the slides? It's always good to have notes. So while those are being prepared, let me try to summarize first in terms of the stakeholders. We likewise went through a similar exercise as the other two groups, came to very similar conclusions in terms of the types of groups that would be included. And we tried to sort of put them into large buckets. And those buckets might start off with things like resuscitation guideline and training organizations, governmental agencies like the NIH, the CDC, medical specialty organizations, specialized organizations, industry, cardiac survivor organizations, and of course other collaborators. And this is, of course, only the beginning, and I do believe we would put together a very, very large organization. I think it'll be important for us to begin to organize it in terms of some of these buckets so that we can figure out what the appropriate representation might be on a collaborative. In terms of articulating the collaboration, there was a notation that we need to get into some definitions. There's a noun, the collaborative, versus the verb to do collaboration, and that it's important that we differentiate those and define what we mean. But it was clear that there was really very clear-cut support in general for the notion of collaboration. I want to go back to our buckets because one of the things that we did is we went by group and asked if these groups would be interested in collaboration. Really, what was the value proposition? And what I can say is that really representatives from, we had virtually all of these organizational types represented in the room, and I believe it would be fair to say that within each of these subtypes, there was felt to be value in a collaborative that would deal with this, with the notion being, I think the simplest unifying theme would be that there's no one of these groups that can do everything required in this very large area. And the idea of working together was a very strong, very compelling theme. There we actually did indeed go through our groups with our patient survivor groups, our federal agencies, research agencies, the big organizational nonprofits like the American Heart Association and Red Cross, industry, and EMS organizations, and everyone felt that there was a very positive value to some collaborative organization. So in terms of short-term priorities, short-term in the first 2 years, these are the things that we look at organizationally as quick wins. It was really felt 3 areas. The first in public education, and that corresponds very nicely with the previous 2 groups. In the area of surveillance, and here what the comment was that we need at least to make a determination of how we will do surveillance in the next period of time. I think because surveillance appears in the long term, it's clear how important surveillance is and how much work there is to do it in that area. And the third area that was identified is the notion of telecommunication guided CPR as being a quick win that in 2 years could very likely really move the needle in survival in many communities. And so these are things that we should do rapidly. Then the long-term priorities could include things like following the Brain Attack Coalition model, the notion of developing the ideas around 3 levels of care, sort of the basic level where you would be CPR ready or cardiac arrest ready for any hospital, the idea of an intermediate receiving hospital, and then a center of excellence. Clearly, the national surveillance strategy would be another long-term priority, and making cardiac arrest a reportable condition at multiple levels, in billing, in diagnosis, in all of the types of areas where right now we are really deviled by the lack of cardiac arrest, that these would be important long-term priorities for the group to work on. In terms of how to operationalize this, the group, I think, was very favorable towards the idea of doing something very soon. And one notion was that it should be on neutral ground, and we floated several ideas. What if we tagged onto an existing meeting? And the idea really was embraced by the room that it would be better to have this on some sort of neutral ground, possibly the National Academy of Sciences, where we are today, as a beginning point for the development of this collaborative. And there was an idea that as the collaborative might move forward, it might be possible to move it to a place like the NIH. And I'm very happy to say that Jeremy Brown has offered his office so that we are able to set up in that office, next month? Is that right, Jeremy? End of this week. So we have an office at the NIH as well, and so we move quickly on this. So the notion would be early on that the umbrella might be something like the IOM with migration to a federal agency. In terms of funding, participating organizations would all pitch in. A meeting should be planned within the next 6 months, so it fits right in with Tom's meeting in 3 months. And that there might be scalable funding. But what I mean by that is smaller organizations would pay a lesser amount, larger organizations would pay a larger amount. And that, like the other groups, the structure might include some sort of an executive group, planning group, yet at the same time the overall group would be all-inclusive with the notion that it would be a group that will take action quickly. Thank you very much. So now this is open for comment from all of you. And we're in sort of the final part of this, and this is the opportunity for all of you who have kind of suffered through this for 2 days to tell us if we got it right or if we've missed something very important. And so please come up to the microphones and let us know if you feel these recommendations or these, we don't make recommendations, these notions of advantages and disadvantages are right on or not.
Sure. Jonathan Epstein from the Red Cross. So I think we're right on, but we had 3 different groups come together with some similar and some dissimilar concepts. Where do we go from here is my question. While we say a meeting in 3 months or 6 months, who's the organizing entity to make that actually happen? That's the question.
So who would you like it to be?
We can go back to the recommendations of the report and start with the organizations listed, but I think that's a very short list. So I'm not sure who it is, but you know, how do we gel these three groups into one meaningful action plan?
So I might respectfully disagree with your comment in the sense that it is amazing to me how similar these three groups are. There are separate rooms. There was no discussion between the two. What I heard was to assemble a group of people that's manageable. Kind of how to do that is probably through the stakeholder organizations, and meet within 6 months to define structure and at least short-term priorities, which I think is remarkable from three separate groups that talked. What about the planning committee? The planning committee could continue to take this forward. They've spent the past 6 months, at least 6 to 9 months, working on assembling this group. That might be an option.
This is Bob Berg at Children's Hospital of Philadelphia. I think to wait for an answer to come from above about that would be sort of a waste of time. I think you guys have worked for a couple of years. I think it's a good idea for you to do it. I don't think that we should retrench from the comment about these being recommendations. They are recommendations, and they flow nicely from the document, from the thoughts that were in this group, and from where the low-hanging fruit were consistently, there was a consistency and consensus, I think, within the room. The only things that there were not complete consistencies about, in my mind, was timing about when all the other groups get brought in. There wasn't a question about the other groups get brought in. It was like timing, and I believe that there was at least what I heard lots of times was doers instead of thinkers, which means get something done the next couple months before we try the perfect. I heard many times that perfect could be the enemy of the good, and you have a set of a lot of ideas that can move forward, and I think we better do it while the irons are hot before we lose momentum.
So I'm David Belkin and a survivor of sudden cardiac arrest. So the first thing I want to say, my event was 9 years ago, and this is the best, most substantive meeting I've been at, because I've been at a lot of meetings, and I think we accomplished really a lot here. And as I envision what we're going to be doing, as long as we move forward, a letter goes out to interested parties, whoever we think the interested parties are, from maybe the members of the sponsoring groups who sponsored this meeting, inviting whoever we believe the stakeholders are. It's an open meeting. And the letter has to include what the purpose of the collaboration is. I don't think a letter written by a large committee is really what we need, because a couple of people who we can delegate to, maybe the committee members, write this letter, and it goes out to the stakeholders. We invite them to a meeting, do a specific date here in DC at this building, assuming we can get it, and we feel like we've moved forward and we've accomplished something here with the 2 days. And I just want to I want to compliment you all for putting this incredible meeting together. The three of you, but everybody else who participated in putting this meeting together. So thank you from a survivor.
Are we ready to meet?
So in following up on that, could Could I make a proposal that the writing or the planning committee for this conference take on the responsibility of putting together the first meeting within the next 6 months? Thoughts and or comments? 3 months.
Letter out in a month, huh? Yeah.
Is anyone opposed to that plan?
Make it after the election.
Okay. All right. I think we have our.
I think we've got our marching orders for a
working
little
orders.
bit. Let's
All right.
see if we've got a comment right here. And please identify yourself again.
Dave Cedar from Maine Medical Center. One of the things that jumped out at me is the scope of this task in front of us. I mean, the IOM report spells out a huge amount of work that needs to be done. And I think that really came out in the discussions we had, that some of them went in all different directions because there were so many different things that need to be tackled. And I just wanted to encourage the formation of task forces or subcommittees to address individual problems, because I think the report as a whole is too much for any small group of individuals to tackle. But if you assign subcommittees to or task forces to deal with the bystander CPR issue, the pre-hospital, quality of pre-hospital CPR issue, the post-resuscitation care issue, the credentialing, and there's so many different issues within the scope of the directive that I think you really need a lot of people to help.
Yeah. So
Thank you.
We in our group, in terms of the success of the collaborative itself, got some phenomenal recommendations from Clive. And Clive, could you repeat the comments you made in our group regarding what to do in terms of starting off a large collaborative like this?
I had 5 things. Start very small, and don't try and do too many things, because success breeds success. So get 1, 2, or 3 things, no more. In fact, 3 is probably too many. So focus on 3 things and let the oak tree grow from an acorn. 2, start small in terms of the number of participants, because you need it to grow and evolve as people get engaged. 3 was rely on the member organizations. Don't build on additional infrastructure on top of the member organizations to get started. 4 was don't have a discrete purpose. Don't try and duplicate what the member organizations are already doing. And the 5th was, help me, 5th. The 5th was trying to make sure that you don't duplicate competencies or tasks in the activities. I think those were the 5, but I'm not quite sure which.
Right. So start small, stay very focused. Pick your initial activities carefully and invest in them and assure success. Do them really well. Don't duplicate tasks. Utilize the expertise of the member organizations. And I thought that was really, really helpful advice.
Thank you. I'm wondering, Tom, if we want to take a minute and let some of our sponsors have a chance to sort of reflect on this. And I'm wondering if, I see Brian hiding in the back there. But Brian, would you be able to just sort of give some impressions on behalf of the Heart Association? Then perhaps we could have somebody from the Red Cross get up and give some impressions. And again, we do want to thank our sponsors. It's the only reason we've had this meeting.
Sure. So thanks, Brian Eigel from the Heart Association, as Lance said. So I think it's been a great 2 days as well. I echo the earlier comments. I think it's been a really good amount of conversation. I think the absolute proof will be in the pudding, though, is now the challenges for all of us to actually go home and now do something with the discussions. I thought the all the conversations were really good. I think the surveillance conversation yesterday, I think Drew's comments about the TCPR was very, very helpful, and I think this afternoon's discussion has also been extremely helpful. So I certainly welcome the ideas of the collaborative. I think if we can really think about ways to shape a path that's the big picture, changing people's minds and getting sort of that mind share of bystanders and professionals to actually take action, and we can stay away from some of the other things that might cause more strife and division, that things that are on business or things that may also get us in trouble with antitrust, anti-competitive types of things. Stay away from all of that, but the collaborative things that we can do, really what Clive outlined as well, I would echo. Those would be a great way forward for this group to really harness the energy and the passion and just the intellect that we've got here. So welcome a meeting in 6 months for sure.
Good.
Yeah, again, Jonathan Epstein from the Red Cross, and I'll let certainly Richard as our Resuscitation Council chair to just weigh in, but I really echo what Brian said. I think from a collaboration perspective, working together has been a great 2 days. I think my greatest concern, and probably speaking on behalf of the organization, is that this doesn't stop here. That's kind of why I asked that probing question when we first started this session of what's next. We got to get that meeting going. I think our concern is that inaction would be a failure from all of us.
Before the election and 6 months go by.
Yeah. So I don't know, Richard, you want to add anything from your perspective?
Sure. Just from the perspective of the volunteers in the resuscitation or in the Scientific Advisory Council, as we've done our work over the years, I think we've identified the importance of all of the organizations that deal with sudden cardiac arrest singing from the same playbook and giving the same message to the community. Not trying to be anti-competitive in any way, but simply that we all have the same goal of improving survival, increasing bystander CPR. So I think a collaborative is a great way for multiple organizations to make sure that they are working in harmony. Not to lose their individual flavor, not to lose their individuality, but to be working to support survival and good neurological outcomes.
Mary Newman, Sudden Cardiac Arrest Foundation. I would like to thank you guys for just a wonderful 2 days. The meeting was exceptional. We were very honored to be asked to be one of the sponsors of this meeting as a way of bringing in patient advocacy groups, and especially appreciate the opportunity to show our video the other day and to share survivor stories, and also in these discussions to bring in the other populations of people who have lost someone to cardiac arrest and representing that. So we appreciate that you gave us this opportunity, and as we said in the video, the final remark was, together we can save more lives.
There are other sponsors, but Dr. Nadkarni, would you like to speak on behalf of Citizen CPR for just a moment? I'll take Dr. Aufderheide off the hook because he's going to talk.
So on behalf of the Citizen CPR Foundation, I think this is exactly the type of coalition and collaboration that we're seeking. Citizen CPR Foundation is trying to be a neutral ground where various industry as well as organizations can meet and interface for saving lives. So I think it fits right in with that. And in whatever the next meeting of the Citizen CPR Foundation ECCU conference will be in New Orleans, December 4th through 8th, and that there's a strategic planning process attached to that right before RES in New Orleans. And so if there's any way that those venues could serve as touch points for any of the activities, I think the foundation would be happy to try to make that happen.
Thank you. Other sponsors, I'm wondering if anybody brave enough.
Well, we have many industry sponsors, and
That's what I
would love to hear from them.
That's just who I was sort of looking for. Normally I pick on the usual people.
Fred Chapman was here earlier. I see
Fred
Clive.
or Ward or Clive, would you just care to make a comment in terms of industries you know, how does industry feel about this, Ward? Clive, would you? Okay. Okay, but we might check your license later. Okay.
Thanks for a great meeting, and I mentioned earlier in a breakout, I think this is a seminal event in terms of bringing all these groups together, and the next step is to organize from many one. That's what I think the opportunity is with the collaborative, to speak with one voice on certain specific topics. And as someone else said at the microphone, it still lets all these organizations fulfill their missions, and Richard mentioned that as well. So, but if we could learn to speak with one voice on the topics that are strategically important to advancing the agenda, if that's what comes out of this, this is a big win for all of us. Thank you.
Thank you, Ward. Clive?
I ditto to what my learned colleague said. So I think that it's been an interesting 2 days. I would go back to some of the things I said earlier and urge to do something and not just talk about doing something as a result of this. That will be the proof of the pudding for as far as we're concerned.
Bob Niskanen.
So Bob Niskanen here with lots of conflicts of interest. Just so you know, I'm here paid for by Physio-Control because I do some consulting with them now. On the other hand, I've been on the board of ECCU, Citizens CPR Foundation, on the board of Southern Cardiac Arrest Foundation, on the board and founder of Take Heart America, and a friend, it's a plaque on the wall, of NAEMSP. What a great group. So compliments to everybody here. These meetings are much more difficult to plan than anybody that attends knows. So the planning committee and the leader is fantastic. My only caution that I have for you is that, as you know, I've been in meetings and meetings and meetings for years all over the world with a great group of dedicated, smart scientists. And in general, they don't do marketing, branding, communications very well, and they don't do business planning, organization very well. It's not in your sweet spot, so rely on others to do that. I'd also encourage you, no, this is a compliment actually, and I'm speaking a little bit for Fred, who I think is off to an airplane, I'm not sure, but from a Physio-Control standpoint, you know they've been very supportive of meetings like this. There's always this careful balance between over conflict of interest, and please work that out clearly, up front, be very open and direct, and you guys and the patients will win. Thanks.
Thank you. Are there any, Tom, any sponsors that I've not picked on so far?
If there are any sponsors who've not had a chance to speak, now is your chance.
Yep, now or forever hold your peace.
Okay.
Well, great. I want to thank you. We're going to draw this session to a close. I want to thank all of you who have participated and my fellow panelists, and we'll now move into the final session.